This client is a university athletics athlete training 4 to 5 times per week. They have a grade 2 right biceps femoris injury. This client is in the mid-phase of rehabilitation, and the aim of this program is to improve stability. Here I am asking the client how their injury has been recently and for them to give me a pain scale of 1 to 10, which they replied to. I ask consent to take the client through the rehabilitation program and explain that this includes them attempting exercises and may require me to alter their positions and get them to answer questions about their injury throughout the session. This allows the client to make an informed decision about their care, and once the client gives me their consent, we can start the session with a ramp warm-up. The exercise I have prescribed the client is a bodyweight squat. The exercise can be seen as appropriate as the BMC Sports Science Medicine and Rehabilitation article from 2022 states. The main knee muscles used during squat exercises are the quadriceps and hamstrings, where co-contractions among these muscles improve stability, supporting that the choice of the squat will contribute to the aim of improving the client's stability post-injury. This exercise requires the client to bend their knees into a sitting position. I demonstrate this and ensure the client knows what to do before allowing them to attempt the exercise, during which I give corrections and ask how they feel and if there's any pain. The coaching points I gave was knee tracking toes, 90-degree knee angle, and neutral spine. I prescribed 4 to 6 reps and 4 to 6 sets for stability to be improved. If the client were to have significant pain or difficulty in execution during that exercise, then regressions can be put in place to allow the client to complete an exercise with more comfort. The first regression I have chosen for the client is a wall sit, where the client can use their hands to get into the correct position, thus putting less stress on the bicep femoris and other muscles involved. Isometric exercises like this are beneficial as they allow controlled muscle activation without putting excessive stress on the injured areas, as well as contributing to developing increased stability. I demonstrate this to the client and remind them to keep their back flat against the wall and keep their knees at a 90-degree angle. This is done for 10 seconds for 4 to 6 sets. Another exercise which may be suitable for a client struggling with a bodyweight squat is a squat to a box. This regression involves the client sitting down onto a box and standing back up. I demonstrate this to the client and remind them to sit down as gently as possible to maximise muscle output. The box height could also be increased or decreased to cater for the client's needs. It is said that influence of the box squat on concentric phase performance is of interest in 2010, supporting that as the hamstrings concentrically contract during the bending stage of a squat, that this will benefit and target the bicep femoris. I prescribe 4 to 6 reps and 4 to 6 sets. A third regression for a bodyweight squat is a squat between 2 boxes using their arms to assist them. This allows the client to get a picture on how the movement should feel and allows them to practice the technique without the added challenge of supporting all of their own body weight. For this, the client squats between 2 boxes and bears their weight with their hands. This allows the client to have full control over how much weight distribution they will place over their injured muscles, in this case the hamstrings. I demonstrate this movement and remind the client of knees tracking toes and neutral spine and prescribe them 4 to 6 repetitions for 4 to 6 sets at a slow tempo. The first progression for a bodyweight squat is a barbell back squat. This involves the client bending their knees into a sitting position with the bar resting on their shoulders, increasing the weight meaning that they have to work against the resistance of the bar as well as their body weight and gravity. It has been researched that barbell back squatting allows athletes to both increase performance and avoid injury by developing a more stable and balanced squat movement, highlighting that this exercise is a suitable progression for developing stability in the client. The coaching points I gave the client were simultaneous triple extension, neutral spine, and breathing in and holding until the movement is complete. It is also important to consider health and safety, such as ensuring that the space is clear. Weight can be added to this bar to increase the stress on the muscles and the output they must exert if the client is progressing. I prescribe 4 to 6 reps and 4 to 6 sets. The second and final progression is a single leg pistol squat. This involves bending the knee into a sitting position at full range of motion whilst maintaining balance and being able to bring themselves back up into a standing position, all completed on just one leg. This would test their stability more than other exercises due to the lack of contact points with the ground, and if done well then would indicate that they were closer to moving into the late phase of rehab. The coaching points were to keep their head up and arms in front whilst keeping their whole foot in contact with the floor. I demonstrated this to the client, and once they understood, they had a go. It was clear to see after the first rep that they did not have the capacity to continue with this exercise, and once prompted, the client communicated with me that they could not do any more due to pain. If the client had been able to, then 4 to 6 reps and 4 to 6 sets would have been prescribed. Instead, the client went back to normal squatting, and after positive feedback, they gave to me, we added a kettlebell to challenge them instead.